Welcome, everyone. I'm Dr. Carmen Poliafito, and I'm happy to welcome today Dr. Ajay Kuriyan, who is from the Wills Eye Hospital, where he is Associate Professor of Ophthalmology.
Thanks for having me,
Ajay,
Dr. Polito.
Ajay, welcome to Retina Synthesis. And we're going to talk today about the use of cooling for anesthesia and intravitreal injection. Can you give us an overview of the technology involved?
Sure. So I think we're all familiar with the use of ice, things like that for anesthesia whenever we get a bump or a bruise. It's one of the oldest forms of anesthesia. And we are all familiar with the different forms of anesthesia that we use for intravitreal injections. And so the goal of the cooling device is to essentially provide a very specific temperature for cooling in a very small area in order to anesthetize for intravitreal injections. The main benefit of the cooling device is that it essentially is very fast. And so when you compare it to some of our longer time-consuming anesthesia methods like subconjunctival lidocaine or lidocaine gel, this would definitely speed things up in the delivery of the anesthesia.
Mhm. So what's the current technology that's being used? What's the setup?
So it's a handheld device with a disposable tip. And so the disposable tip is sterile. And so essentially use a new tip for every single patient, and you deliver the cooling over 15 seconds, and then you perform the injection right after that.
Mm-hmm. Is the handheld device attached to a tank or anything like that, or is it all self-contained?
It's all self-contained. It basically looks like a small device you can just hold in your hand and then press right up to the eye, and you press it essentially right at the limbus, and then there's some feedback that you get from the machine that tells you that the cooling has been applied, and then you inject right after that.
This procedure has been studied in a number of clinical trials. Can you discuss some of the clinical trial results and the design of the trials?
Sure. So the trials that have already been completed were open label trials. So Cool 1 was essentially just looking at a dose response for the cooling. And so it's just three different arms, minus 10 degrees for 20 seconds, minus 15 degrees for 15 seconds, and minus 15 degrees for 20 seconds. What they found in that study was that the patients had the best response to the minus 15 degrees for 15 seconds. And so that resulted in a second study, Cool 2, which was in patients who had previously undergone subconjunctival lidocaine for their anesthesia, underwent either 15 degrees at 10 seconds or 15 degrees at 15 seconds. And what they found in that study is that the patients in the minus 15 degrees at 10 seconds had pretty similar pain scores to historical controls with lidocaine gel. And then when you ask these patients which anesthesia they preferred, an overwhelming 82% preferred the cooling device. And a lot of feedback that they got was that even though the injection with subconjunctival anesthesia felt similar to the injection with the cooling in terms of pain, what they noticed was that the after effects were a lot better. The eye didn't feel as irritated. There was way less subconjunctival hemorrhages. And so that's why the patients in that study preferred the cooling method. And so now we're doing a head-to-head between lidocaine gel versus the cooling device in a non-inferiority study. And that's Cool 3 that's currently underway and is in the process of completing enrollment.
What's the study design like for Cool 3?
So that's a randomized trial where we're essentially randomizing to either lidocaine gel with a sham cooling versus a sham gel with the cooling device.
Mm-hmm. Oh, that's very clever. That is very, very clever. Yeah. Do you use this routinely in your practice these days?
So
Or
I don't.
some of your practice?
Yeah, it's still under the clinical trial at this point, and so we're waiting for FDA approval before it's available for our regular clinical practice. Overall, just from feedback from some of the people who are involved in the clinical trial, it's been very favorable. We're very interested in seeing how the impact would be for throughput in clinics, especially in clinics that rely heavily on lidocaine gel and subconjunctival lidocaine for their anesthesia.
Mhm. The going back to the cooling device, how does it get there's no liquid nitrogen or other external coolant. How does the cooling device get cold?
So that's definitely a good question for Gunho Kim, the CEO of Recents, who essentially developed the technology.
Hmm.
I'm not certain exactly the mechanisms in which that they have engineered the ability for it to maintain the cooling and keep the cooling at the proper temperature, but I know that that was their biggest hurdle, to be able to have such a fine-tuned device for ensuring that the proper temperature was there, that didn't result in any tissue damage, was what they were working on for a while from the engineering side of it.
How many applications does it work for? Before it needs to be is it a so-called rechargeable device?
Yes, yeah, the device itself is rechargeable. The tips are the part that's disposable. And so the device itself, it has a charging dock, and is essentially designed to last an entire clinic day. And then the disposable tips are disposed between every single patient.
Mhm. Do you have an idea of what the pharmacoeconomics of this procedure would be?
I think that they're still waiting for approval before they can figure out all those aspects of it. I think the goal would be able to have it increase your speed in clinic, to offset that cost of the cooling device itself.
Mhm. Um, how does it affect the transaction time
Um,
in your classical clinic? How are you doing anesthesia? How much time is it taking you per patient, and compared to the use of the cooling device?
Yeah, so I think it all depends on your type of anesthesia. And so if you're using lidocaine gel, where you usually let that gel sit there for a few minutes, or if you're using subconjunctival lidocaine, where you have to perform the lidocaine injection, leave, and then come back after a certain amount of time, that's where the cooling device is going to be much faster, because you're essentially putting it on for like 10 seconds and then performing the injection right after that. And so it essentially is very similar to if you're using topical drops.
Hmm. So, how much? So, what is your personal? Do you use gel or uh, lidocaine, subcons lidocaine right now, or?
So I use mostly topical drops for most of my patients, but then in a subset of patients who are not able to tolerate just topical drops, then I use either subconjunctival lidocaine or a plugit prior to injection. And
Hmm.
so for those subconjunctival lidocaine patients where you have to go in and perform an injection, then come back after like 5 to 10 minutes, that's where that patient staying in that room for that
Hmm.
period of time is definitely the biggest thing that I think something like this device would help improve, because it would essentially free up your chair time so that it would allow another patient to come into that room, improve your clinic flow.
Yeah, and the number of injections, the average. Do we have an idea of what the average number of injections the retina specialists are doing these days per day?
I don't know. I'm sure it varies a lot between practices and locations.
But it could be. I mean, there are clinics where an individual surgeon is approaching 100 injections a day. So the
Yeah.
transaction time there is crucial.
Yes, definitely.
It's crucial because basically it's space and time are
Mhm.
competing for resources. So when will the cool
Exactly.
when will the Cool 3 trial be over?
So we're hoping that the enrollment will be finished very soon, hopefully within the next few weeks. And so then it's going to take some time to analyze the data, but we're very excited about bringing it to completion and taking a look at the data to see how it does.
Oh, great, AJ. Thanks a lot for your discussion of cooling anesthesia for intravitreal injection. It sounds promising.
Well, thank you so much, and thanks for having me on, Dr. Polifito. It's always great seeing you.